Good evening, everyone. My name is Catherine. I am a clinical lab consultant with WAVE, and thank you for joining our webcast this evening. Tonight, we're excited to have Dr. Aaron Wolf joining us to share some really interesting scleral cases that he designed with the Eaglet ESP and Pinnacam CSP scans. There should be a chat box for everyone on your GoToWebinar screen where you can enter questions. Please feel free to enter those during or immediately after the presentation, and then we'll have some time at the end to go through those questions. And again, we are pleased to have Dr. Wolf with us tonight. Dr. Wolf received his Doctorate of Optometry degree from the University of Houston in 2009. He is the owner of Austin Optometry Group, a private practice in Austin, Texas. And his practice focuses on ocular surface disease and specialty contact lenses. He is a fellow of the American Academy of Optometry and a fellow of the ScleraLens Society and a fellow of the International Academy of Orthokeratology and Myopia Control. Dr. Wolf provides topography-guided corneal, scleral, and orthokeratology lenses, impression-based lenses, and custom HOA correcting lenses. He has fit more than 1,500 ScleraLens cases and more than 500 orthokeratology cases. He's also a key opinion leader for several anterior surface imaging manufacturers and specialty lens manufacturers. So on behalf of WAVE, thank you so much, Dr. Wolf, for presenting this evening for us. And with that, we can go ahead and turn it over to you and let you start the presentation.
Well, thanks for having me. Essentially, the presentation's on scleral lenses, so we're not going to cover anything besides that. And then, I have the Eaglet and the Pinnacam CSP Pro, so we're going to basically walk through a couple cases on those. We're not going to probably get through all of them. I think there's 5 cases. We'll get as far as we can, and then we'll kind of look at, how each instrument works with the WAVE. My assumption is everybody on the call either is already using WAVE or they're maybe about to start using WAVE, so they probably have a pretty good understanding of that software. I don't know how many people on the call are already using imaging devices for the sclera, like the Eaglet Eye Surface Profiler or the CSP Pro. But that'll be a large part of the presentation. So we'll kind of talk through what the instruments give us and kind of how to best use them. So for the Eaglet, a couple quick tips and tricks. I've been using the Eaglet now for about 3.5 years, and we do all of our lenses through mapping, either mapping or impressions. I think maybe only a small couple handful of times that in the last 3.5 years since COVID, we've done a fitting through a fit set. So we just use the imaging for everything. The Eaglet is a tear film mapping device, kind of like your more traditional Placido disc devices would be, but this is using Fourier imaging. So it's actually going to project essentially 2 different essentially grids onto the eye, and then it'll essentially map out the tear film that way. So being that it is tear film dependent, we will prep the patients for a few days before they come in really aggressively with some preservative-free hyaluronic acid drops. There's a number of them on the market. After trying basically all of them, I found that the Optface MGD Advanced just works the best, but you can experiment with that. We do have them stop wearing their lenses, both soft lenses as well as any kind of scleral lenses before several days before they come in. Soft lenses usually only need like a day or 2, but scleral lenses is really best to give them several days. You're going to numb the eye. Okay, I think that regular proparacaine just works better than using some kind of combination drop like Altaflor. These are 2-person jobs. Okay, so you're really going to want somebody using the instrument, kind of driving the instrument, and then another person holding the lids. My recommendation is have the doctor hold the lids. Okay, it's really not that hard for somebody to kind of point and shoot with the joystick, and honestly your techs handle instruments like that way more often than you do with the other instruments that they're using in the office. It's much harder to essentially control the eyelids. And then, as you can see on the photo, what you're really trying to do is block the lid against the orbital bones, and that just works a lot better than using your fingers and pulling up that way. Do take several pictures and then essentially assess the best ones later. But essentially, take a picture, blink and blink, open the lid, take a picture, and just do that several times, and then assess. And if you might have to do it again, you can do it again. The scleral blessing is essentially just when you're applying the dye. It's kind of a Catholic reference. Top, bottom, left, and right. Top, bottom, left, right. You're just gonna kind of dab the fluorescein across those four kind of quadrants of the eye, and then 2 strips work way better than one. So just take 2 fluorescein strips, win both. So again, this is tear film dependent. Moving on to the PenCam CSP Pro, that's the instrument that I use. I do not have any experience with the CSP Basic or the regular CSP. To my knowledge, the main difference is just, the CSP is going to take 5 images and stitch them together. The CSP Pro, you can actually take everything in one image, up to about 18 millimeters. And if you need to take additional to fill in the gaps, you can, but the main advantage is that you can try to get everything in a single shot, which is, in my opinion, better. So this is not a tear film dependent device, but I do still recommend really prepping the eyes ahead of time with the fluorescein. I'm sorry, not the fluorescein. Don't use fluorescein. That will definitely screw up your image just because that blue light that shines at the eye. But with a preservative-free hyaluronic acid eye drop, just because if there is any irritation in the eye or SPK, basically it can potentially affect the scan kind of getting through. It's essentially kind of like almost like an OCT kind of scan. It's a tomography scan, obviously. So you do still want the best ocular surface possible, but the advantages with the CSP Pro is essentially, I guess, more quote unquote kind of real data, because it's not as dependent on the tear film. If the scan can kind of get through that tissue, it's going to give you really good information. So there's advantages to using that instrument. And then sometimes there's advantages to using the eaglet in the sense that, if you have a lot of scar tissue or a really irregular graft or something, sometimes the CSP and the CSP Pro might struggle for the tomography shine fluid signal to get through there. Whereas, if you're just mapping the tear film over that structure, it doesn't really matter what's underneath it as far as, that irregularity or scar tissue. So they both have their pros and cons, really. Also a 2-person job. You're also going to numb the eye. Q-tips or the Oculus lid stick are both, either one of those is going to work better than your fingers. My opinion, if you're using the CSP Pro, you really want to try to get everything you can in one shot, the best that you possibly can. Really emphasize that. But if you can't, you can stitch it together. Let's see here. So we're going to dive into the first case. This case was with the eaglet, and this is just, our bread and butter kind of keratoconus case. 30-year-old black male, right eye keratoconus, worse in the left eye, referral from ophthalmology, not good vision on the right eye, pretty decent vision on the left eye, really. Wave, a great option for, most any case, but really wanted something with a lot of, worked well with the eaglet, and the wave's proven to work very well with the eaglet. So we put a diagnostic lens on the eye after we take the eaglet scans. Again, pretty good vision in both eyes. Going to be a little bit better in the left than that right one. And then underneath here, you're going to see this referenced on my slides quite a bit. And this is not from the literature, at least not yet. But this is not from the literature. This is what I call the Aaron Wolf School of Profilometry hard knock. So this is just my approach after using profilometry for a few years now, that you're going to want to take the HVID and just essentially add 2 millimeters to it, and that's the core that you want to kind of assess your measurements. The reason for that is essentially, as we know, with the ScleraLens landing on the eye, you're kind of looking for this like evenly distributed kind of midfoot, just kind of use that reference of your foot, right? We've heard that terms with the toes and the heels, in regards to the landing zones of the lenses. You really want that midfoot to be where that balance is at. And so just based on where the HVID is, and then where the lens is going to kind of first land, just beyond that, 2 millimeters, maybe 2.5 or something, that's kind of like your sweet spot for kind of middle of these landing zones. So that's really where that support is from. So you'll see that reference there. And then less than 100 microns, that's just not much toricity or asymmetry to the eye. So it doesn't really matter too much, GSIM freeform impression lenses or whatever, there's not much toricity. The lens may rotate. So just keep your expectations, proportional. 100, 150, that's decent. So, you might get a little mild rotation, a few degrees or something, but it should be in the ballpark of stability. And if you use the free form, I think you'll get an increased stability, increased precision there. And generally over 150 microns, you're good. Okay, that lens should stay right where it should be, and that's important. When doing maybe like front surface toric optics or multifocals, if you're going to decenter or anything. So in some regards, the higher the toricity of the sclera, the better. When it comes to scleral lenses. So this eye's got a pretty good amount. When you're looking at the eaglet, just to get kind of lay of the land, this color map is kind of like your traditional topographical map. Reds are going to be higher, blues and greens are going to be a little bit lower. On the left, you just, select your chord. This chord's set for, the 2 millimeters past HVID, like I mentioned. And then you're going to see average heights there. Your 90 min, 90 max. That's basically kind of like what SIMK is on the cornea. It's essentially the same principle, but on the sclera, it's just kind of your main scleral meridians, 90 degrees apart from each other. And then other data obviously is useful, but mainly you're going to be looking at that difference is highlighted there. On the right, it's kind of like your normal corneal topography information, and then you also have some metrics down at the bottom. So really pretty robust metrics on this main page. You can look at some other maps, anything from corneal maps, your tangent angles maps. You're not going to use clinically really, other than to assess the quality of your images. And when you're trying to decide which is the best map that you want to design a lens on, you do want to reference that one. And the smoother the colors, essentially the better. And then the eaglet will essentially give you quality scores as far as your focus centration. So that's also really helpful in determining which lens you want to go with. Keratoconus progression, keratoconus probability index, that's something that is helpful, but you basically probably already know if they're getting to this point that you're mapping the sclera. So this is the left eye, again, pretty good toricity in the sclera and good quality scans. So we import those, or I should say export those, into the Wave software, and this is your typical design page. I think probably all of us, or most all of us, are operating on the newest software, and if you do, this is essentially what your screen will look like. You can adjust, your preferences. I will have to reference what we did on this one. I think we did 4.5 millimeters past HVID, and this is how the lens came out. So first lens right off the bat, looking beautiful. Centration looks great. Again, because we have a good amount of sclerotoricity, the centration or the stability looks good. The markings don't look like this anymore. This was a while back when we were kind of fine-tuning what the markings would look like on these lenses. So they will just have the 6 o'clock marks. They won't have that 3 and 9 mark. Okay, so ignore that, but the fit looks beautiful. This is a one and done fit. Didn't need any adjustments. We did just do that HVID plus 4.5 millimeters. That's a really nice, kind of starting point if you're not really sure. I would recommend that, and starting with that 350 micron clearance. That doesn't mean that's what the lens will actually be on the eye. This lens, after settling, was about 280, but that's just a good place on the software to kind of start with. Okay, vision ended up being fantastic, even better than the diagnostic lens gave us, and he says best vision he's had in years. So that is your keratoconus from the eaglet. So case 2, we're going to do another one. Just do another keratoconus case, but from the CSP Pro. So this is a 45-year-old black male. Again, right eye worse than the left eye. He was already in scleral lenses. He hadn't seen his doctor for a couple years, and of course, the lens wasn't bad, but it wasn't ideal, or it wasn't, I guess, current possibly, right? So he ended up having some issues, a lot of limbal bearing, microcystic edema of the limbus, and neovascularization. All in all, this eye was really red, angry. It just was kind of in bad shape. Vision, even through the scleral lens, was counting fingers in that eye. It was no good. So to, typically go from one ScleraLens to the next, if everything's good and healthy, we'll just have them discontinue the lenses for anywhere from 3 to 5 days, depending on what that lens looked like. But this eye was not healthy. So what we did is we actually just said, hey, we got to get this eye healthy first, however long that takes. So we washed him out and treated him, or I washed him out and treated him over about 3 months. Amniotic membrane, Restasis, eye drops, Optase ointment, vitamin A. And then we just monitored several times until that eye really looked like it had bounced back. The reason I wanted to go with the wave lens as opposed to other ones was, I wanted the kind of freeform compatibility just to get the lens as centered as possible. I like thinner lenses. It's kind of some personal preference. Wave tends to have, kind of a thinner, I guess, overall design. Of course, you can make it thicker or thinner, but generally it will kind of give you more or less the thinnest lens that's structurally good for that design. That's my personal preference as far as oxygen transfer. I also like typically lower clearance lenses with a freeform design. I feel like you get a little bit more predictability in the settling than you do in some more traditional designs. And then fenestration, I did not use that on this case. I haven't yet needed it actually, but I like that such a thing may be a possibility with these. So I need that possibly in my back pocket just for a limbal stem cell deficiency kind of case. And then as we're going to see, oval optic zones, this ended up being a neat case to try that out. Anybody on the call who maybe does a good amount of orthokeratology, and especially orthokeratology on high stigmatism corneas, may have experimented with some oval optic zones on ortho K. I was curious, well, would that be something that would work on something like a more pronounced keratoconic eye? In theory, it seems like it should. So we'll see how that one comes out in this case. All right, so this is a really angry eye before, we washed it out. We did the treatment like I just mentioned. And then after 3 months, it was looking really healthy, right? So I felt like, okay, I think we're healthy enough that we can dive back in. We'll just have to watch this guy very carefully. So here is his post-washout Pinacam maps. Okay, so anybody that has a Pinacam, this is a very typical map that you're going to look at. You're going to see pretty significant keratoconus. It's probably K-max in the ballpark of 70-ish diopters. The thinnest corneal spot's about 304, so that's, again, pretty severe keratoconus. Your elevation map, your front elevation map, that's relevant in this case for sure. So that's going to end up being roughly around 200 microns elevation difference at 8 millimeters. So that's pretty extreme, really. And then this is the CSP. So again, the CSP Pro, you can get everything in essentially one shot. That's always my preference. I will try as hard as I can to do that because I just don't generally like the idea of stitching together, data and merging or averaging data points. I just want true data in one go. So now, but if you're using the basic CSP, your view here may look a little bit different. But you can see that there's about 115 microns toricity at that, HFID plus 2 millimeter rule that I like to personally go by. And so that's not that much, right? If you go back to kind of one of those previous scans, 100, 150 is kind of like, it's okay, but it's not the greatest. But, surprisingly, there's about 200 microns difference in the cornea. So there's a lot of toricity in the cornea, but not, it didn't carry on the sclera as much as we would generally anticipate. Diagnostic lens, it was still kind of reduced about 20/60 on the right eye, even, after the eye was kind of pretty good. So not totally sure at this point what that eye is going to be capable of. So this is his maps for the right eye. Again, we just took the Pinacam CSP Pro data, exported it, and then went with the default map. I went with the HPD plus the 4.5 millimeters, and then this is what it spits out. And then below is the results. Okay, so you can see a couple things. One, when we're looking at the profile view from the Wave software, you can see how accurately it predicts the actual cornea, even to the extent of tilt while looking at the visual axis. So if you compare that to OCT, it's like spot on, okay? Second to that, when we're looking at the actual fit, the shape of the lens looks great. It's very well predicted. We do have a little issue, and so we do have to kind of assess these lenses and adjust. So what are we seeing on the image? The top left image is a horizontal scan, and then the top right one is a vertical scan. If you are on a laptop, if you're on a laptop or your desktop, my recommendation is just to crank up your brightness setting, just so you can kind of see this maybe a little bit better. So the challenge, I guess, in this case is that we've got a little bit some nasal touch there, as you can see. The other challenge is that because this is a 200 micron contorticity cornea, we've got this really kind of excessive vertical limbus kind of clearance, which again on an eye that's already maybe a little bit thick. I don't want just a ton of space in that area, because I don't want a ton of suction, kind of irritating that limbus. And then we have a high minus lens. I mean, this lens, I think right now is about a minus 13.6 is kind of how it pans out from the default settings. So what can we do about it? We have different things we can consider. So one consideration is essentially we can just increase the clearance, right? That's the simplest thing to do. Normally works on our lenses when we have a little bit of touch. We just raise the height of the lens. The increase over to the right, basically we increase the clearance. That does fix that nasal touch, but the problem is that really just kind of worsens that kind of limbal clearance in the vertical, maybe even exacerbating some of that vascular congestion and stress on that limbus area. So maybe not the most ideal option. We can, second that, we can flatten the base curve. If we flatten the base curve, that usually works too, to kind of get us over kind of a localized spot. But if we flatten the base curve, we've actually, same thing, we've essentially worsened that vertical excess clearance. We haven't done anything to help it. All right, then next we can kind of do a combination of things. We can increase the height of the lens, the sagittal height of the lens, which would give us over that spot, and then we can steepen the curve, which in theory would maybe bring us closer to that vertical meridian of the cornea. The downside with that is that's going to add minus to an already really high minus lens, already about a minus 13.5. Now we're going to make it a minus, 15, 16 lens. That's also not really great, especially on a lens we're being very, very careful with. Okay, all right, moving on. We can move the optic zones. That's a really cool feature within Wave that many designs, or I'd say most designs, cannot do. So you could, in theory, move the optic zone nasally, and that may also potentially work. The problem in this particular eyeball with moving the optic zone is that if you remember, there's only about 150 microns of scleral toricity, which in his particular case, that's not that much. So it may stay stable or it may not. If he had like 150, 180, 220, some number like that, then that lens is going to lock into position really well, and that might actually be a really fantastic, use of the software to do that. In his particular case, if I move the optic zone a millimeter or two, nasally, and then that lens wants to rotate, now I'm kind of all over the place with my optics. All right, last option. This is what I went with. So I, flatten the base curve to kind of get over that nasal area, and then created an oval optic zone. So essentially an oval optic zone, it's just bringing the point in which that lens is going to first kind of diverge from, that optic zone. It's going to take a little bit of a shorter path to essentially the landing zone than if I kept it at a full size optic zone. So it can be a little bit hard to visualize conceptually. We can revisit that in the questions if anybody does have any questions about that. But this is kind of the approach I wanted to experiment with and see how it compared to some of our Ortho-K kind of oval optic zones. So this is a second lens. I did increase the overall diameter, just to get a little bit of a wider, functional diameter of the lens, which is essentially that internal kind of chamber, where the fluid, reservoir would be, and where that lens first lands on the eye. That's the PFDL. And then I flattened the base curve about 2 diopters, to 5 millimeters in this area of base curve is going to be about 2 diopters. Sometimes in different base curves, that's going to be different. And then I just said, okay, let me just start with 1 millimeter difference. So horizontal optical diameter was 8.7 millimeters wide, and then the vertical, I just started with 7.7 because, just have to start somewhere. All right, this is how it came out. So I did actually achieve what I wanted to do, where I vaulted over that nasal spot. And I don't know if it's a whole lot better, really, as far as that vertical area. It looks like it may or may not be too different. But now I also notice on this lens, I'm getting just a little bit of some kind of fluid reservoir debris. But you can see in the wave display and the map over here, this is what the back surface is going to look like. You kind of appreciate kind of an oval zone there. All right, so wanted to try again. I said, all right, maybe we just go a little bit more. We're experimenting here. So I did 1.5 millimeters. And then now that I felt pretty confident that this was kind of working and I was kind of getting over that area and making the lens overall just a little bit bigger, also added a little bit of some side height to it. Let me go back to kind of steepening the lens and see if I can't, with the combination of steepening the base curve back a little bit, and then, the oval optic zone, see if I can't kind of hug a little bit tighter to that vertical meridian, and then get rid of some of the midday fogging. I just steepened the edges about 50 microns everywhere. And again, you'll see that a little bit more prominent oval optic zone here on the map. And then as far as the lens, I've essentially achieved what I think is probably, it's at least good enough, if not maybe as good as it'll get. So I've got clearance, my optics look aligned. I got rid of the midday fogging. If I look at that vertical meridian, the lens does touch, it does not touch, but it does align a little bit tighter to the vertical meridian, so I don't have nearly as much space there. So this is certainly the best I feel like I'm going to get, or that I want to get. I don't know if it's worth going any smaller in the vertical meridian than a 7.2 optic zone diameter. I feel like less than that may potentially cause some issues with some scotopic vision, and so I didn't want to push it. But 1.5 millimeters seemed to work pretty good. So here's essentially a summary: a spherical optic zone, top left, a little bit of an oval optic zone, and then on the bottom, a little bit more prominent oval optic zone. And then if you can crank up the brightness on your screens, you can kind of see the back of the lens seems to be getting a little bit closer to that vertical meridian, a little bit more aligned. So for me, this was fantastic. This is what the lens looks like on his eye. Eye still white and healthy. Overall, we got maybe the tiniest little bit of some inferior conjunctival prolapse, but that's not a bad thing. We got about 150 microns of apical clearance, which is really what I particularly want, especially in a case like this where I'm trying to just really crank up as much oxygen to the cornea as I can. So this was exciting. So something to consider in any future, more pronounced kind of central cone cases is potential use for an oval optic zone. All right, we're going to transition back to the eaglet, and this time more back to a quote unquote kind of regular cornea. Dry eye patient, failed in previous multifocal toric lenses, not a candidate for daily disposables just based on what's available. And really just wanted better comfort, from a dry standpoint, but with good optics. So as everybody knows, Wave makes, fantastic multifocals. I wanted to see how this case would come out in a ScleraLens. So patient ended up, refracting to 20/20 through a diagnostic lens, right eye dominant. Spectacle ad was about 250, but I always like to do what I call a minimum ad. So once I have them over refracted through a diagnostic lens, I like to see what's the least amount of ad that gets them pretty happy with their near vision. They may want it 225, might be better than 2 or 250, but what's the least amount that's going to really, satisfy their needs? And that's typically what I'll put into the multifocal contact lens. This case, again, not much sclerotoricity, 80 and 100, it's not a lot. So not a huge deal, but I have to factor that in as far as multifocal centration. All right, this is the right eye. Okay, as you can see from the map, pretty much more or less the same color in most areas of the sclera, 80 microns turisty on the right, and on the left eye, maybe a little bit more. This is a pretty small cornea, really, 11, 11 and a half, maybe a little bit more, 11.7, relatively small. All right, so this is the Wave design, and on the right, see how the lens came out. So again, the Wave software and the way it imports the data is going to give you such an accurate representation of the cornea that even when you take an OCT, this looks like mirror images as far as the cornea goes. It's really remarkable to me. And then the same thing with the shape of the lens, right? So the prediction from the lens profile view, it just matches exactly. Going on to the left eye, same thing. So this is how that lens looked, and you can see from the dot on the right eye that we are going to get some rotation at 80 microns. Again, there's no lens in the world is basically going to get it from rotating, if there's only 80 microns. And then the left eye, maybe same thing, maybe just a little bit of some rotation, kind of counterclockwise on that left eye. Optics look good. I opted to start with basically a center distance design on the right and a center near design on the non-dominant left eye. That's served me well in the past, but getting some good feedback from Ken Mahler, at the Wave users meeting back at GSLS. He said, hey, they usually work great in distance, center, and both eyes. So, try that unless, you ever really have to move from there. So it's all right. This patient, they had great vision at distance and great vision at near, but they felt like maybe the intermediate vision wasn't quite as good as they'd hoped for. Other than that, if it looked, really nice, might just could use to be a little bit bigger. And so I just made the lens, just moved it up to 16 on both and kind of widened that little chamber inside the eye. And then I basically just changed the design of the optics to a center distance in both eyes. This is just the change essentially to the optic zone. I'm sorry, not the optic zone, but the overall diameter, and changing the center distance design. And this is what it looks like. So again, beautiful fit. As far as rotation, it still may or may not, rotate some. These, seem to be looking really good at this moment, but you can see the optics look great with the topography over the lens. Patient was very, very happy. 20/20 is everywhere. Intermediate vision much improved. Fit, looking perfect. Great results. So I want to see, okay, how does the Pinacam CSP Pro work with a similar case? This patient's 35, so they don't need the multifocal yet. They are a dry case with some autoimmune issues, and failed out of some, common daily disposables that we'll sometimes, try for dry eye. So this is their CSP Pro maps, okay? Again, the touristy of the sclera over here, 43 microns, is essentially nothing. That's a very, very spherical cornea, but a pretty large cornea, okay? So now we're going to, because it's such a large cornea, we're measuring out about a 15 millimeter chord. And then when we look over here on the left eye, a little bit better with about 113 microns, okay? Other than that, it's pretty normal looking eye. And then, vision can be corrected to normal 20/20. All right, we already covered that this lens is probably going to rotate a little bit on the right eye, may or may not on the left eye. And then this is the default freeform Pinacam Wave design over here on your left. And then on the right, you can see how that lens came out. So it looks beautiful. Alignment everywhere. We go to the left eye, same thing. It ended up coming out really, really great. And this is what it looks like with the photos. So again, on the right eye, you'll see that dot rotating a little bit because that was about the 43 micron sclera. There's nothing to really do to keep that from happening, and that's fine. On the left eye, again, about 115 or something. So that's going to be, pretty locked in. Fit looks great. I always like to evaluate all my lenses in infrared. If you have a camera that has infrared, I feel like it gives me a lot of good information, whether it's corneal lenses, ortho-case, sclerals, just regarding like, the optic zones and, movement of the lens. I can stare at the lens for longer without worrying about the patient, squinting or being, photophobic from the light. So I can really take my time assessing a lot of features of the lens. So there's not that much left for me to to have to look at when I turn the light on. So that's just a neat little trick if any of y'all are not doing that. We, again, 2015 vision through these lenses. And then comfort for most of the day, which, that's a pretty big win in this particular patient's situation. That's 12 hours is a big accomplishment given the severity of her dry eye. We're going to skip case 5, other than to say this is just another multifocal case. This patient's got, easier to work with because they got more toricity of the sclera. You can see how beautiful the images are coming out and how beautiful the lenses are coming out. Okay, a couple small little adjustments. This one, I did particularly stay with a center distance optic zone for the right eye and a near center optic zone for the left eye. But again, beautiful, beautiful fit from the eaglet in this particular case. The only thing that I want to point out on this case is I was very happy with the results, and we ended up at about 190 microns clearance on the right, which I'm happy with, and 240 microns clearance on the left after fully settling. But because I already had to make a third lens just to tinker with the over-refraction, I was curious, how precise is the Wave software and / how precise are the lathes that are cutting the lens? So what I did as part of that experiment is I added 30 microns to the right eye, and I'd subtracted 20 microns on the left eye to try to get a target of 220, right? So if you see, I have about 190 microns clearance in the right, let me just say, hey, let me just add 30, arbitrarily in the software since I have to make the lens anyways, and let me do the same thing on the left eye and just see how it pans out. So then the lens comes back, everything looks great. Again, a beautiful distance center design on the right, near center design on the left, as you can see in the topography. Well-centered lenses, looks awesome. And then again, vision is great. 20/20 far away and near it up close. And then by doing it, even just by adjusting within the Wave software, like 30 microns, it did actually work. It did actually take it from 190 about 220, and the 240 came down to 220. So there's almost no time in which you're ever going to, do something as small as 20, 30 microns or something sag height on a ScleraLens. But it was kind of fun to see that the software in the lathe, they are actually doing what you're asking it to do, even as precise as that. So that's all I got. Catherine and Shelby, if y'all want to, let me know if there are any questions.
Yeah, thank you so much. That was great. Thank you so much for going through your cases. I do have a couple questions here if you are ready.
Yeah.
Okay. And so one of the first ones was, how do you usually determine to use an impression-based lens rather than a software-designed lens?
Yeah, it's a really good question. There's a lot of factors. Some of it will be logistics, and when I say logistics, it'll be essentially how quickly do you essentially want to, I guess, wrap up your project. So if they are traveling a little bit of a further distance, or they have really busy schedules, and they're just not able to come into the office for any number of different reasons, or maybe you're really busy. Maybe your schedule is just like you're just booked out for some reason. You're short staff, you took vacation or something, and now you're like, hey, I don't want this case to drag on with a lot of visits or something. The impression lens is probably going to shave off, 1 or 2 visits, because that first lens, it's not to say that from an impression that lens is always going to be perfect. You certainly, I have 3 patients on the schedule this Friday for impression lenses, and my last patient I just saw this afternoon before having this webinar was in impression lens, and her first lens does require just a little adjusting. So it does happen. But usually it doesn't. Usually that first lens is kind of pretty quote unquote perfect, and therefore it just speeds up the overall process. With the maps, you can get the same result that way too. It just kind of depends on the eye, right? So if you got a very severe dry eye case and the instrument that maybe you're working on is eaglet, and you're thinking maybe on a tear film based device, I'm not 100% sure I'm going to get the absolute best quality maps I can get, then maybe I don't use something that's tear film dependent. Or if the only device you have is like a Pinacam, and you've got like a pretty dense, yeah, whatever peripheral scar, you got like some kind of weird, graft or some, very prominent pinguecula or something that you're just maybe not sure that the quality of the data, it seems maybe a little questionable, and you just don't want to leave it up to chance, then maybe something like an impression lens. So sometimes it's logistics, sometimes it's clinical, different factors.
Yep, those are great points. And then the next question are, what are the most common adjustments in terms of fit that you're making with eaglet designs?
From eaglet, I don't find anything different from the eaglet than the CSP Pro. I'm not finding like I'm getting like more adjustments in one, part of the software or results or something than the other per se. Earlier on, some of these cases might have referenced it, or I went pretty quick through them all, but we didn't know, hey, what's the best like diameter lens to basically select. 4 millimeters past HBOD, 4.5. With the eaglet, I will say it will automatically measure your HBID, but I highly recommend you double check it. You can right click on your map, and then when you right click, it'll show you HBID, and then just make sure that what the computer thinks the HBID is, you also agree, because if you don't double check that and it's not accurate, the software only knows what the data tells it, and so therefore you can sometimes get kind of inappropriate limbal clearance or something in that area. So I'll double check that. If I'm going to make any adjustments, usually it's more in that chamber, what's called the primary functional diameter of the lens, or the PFDL. Usually, if I'm going to do anything, I might increase that area a little bit. And the easiest way to do that is just increase the overall diameter of the lens. And when you pull the OAD out, it will automatically pull that area out for you, so you don't have to really get too creative with the software. Base curves are very almost always accurate. You don't really have to mess with that too much unless you're trying to adjust your powers. And haptics are generally very, or landing zones, the edges, those are generally very, very accurate. But some of that adjustment is going to come down to personal preference, like what one person, I guess, likes to see, and versus another person, as far as how much a little bit of tear exchange or how tight they like that seal.
Okay, yeah, that makes sense. And another question was if you ever use prism on your scleral lenses to improve centration at all?
I don't. I don't like prism on the ScleraLens, and I don't know if I feel like it's totally necessary, at least in the ScleraLens. I think even in those cases where you don't have much scleral toricity, unless you've got maybe like a high amount of maybe front surface astigmatism or something, and you really need that lens kind of locked in, that might be an opportunity for it. But I don't remember a case in which I felt like I really needed it. If you have a very, very, more or less spherical sclera, and again, you've got like a lot of, internal astigmatism, that's probably one of those kind of few cases, or you're trying to decenter a multifocal optic zone or something. But it's there for you. I mean, the software obviously lets you do it, but that's going to be a pretty rare thing, I think, on a scleral that you're going to need.
Okay.
And that's with the caveat of if it's coming from a scleral topographer like CSP, CSP Pro, or Eaglet. Like if you're not using those and you're kind of trying to design a wave scleral lens with like GSIM, just from, I guess maybe your corneal topography and kind of extrapolating some, I guess, that information out to the edge, and maybe you might do so. But with one of these instruments that's actually taking real data from that area, I would just keep it in free form, and you shouldn't really have to mess with it.
Yeah, great. And everything on your cases, everything seemed to align really well, so that's great. And do you recommend using the Eaglet for your Ortho K and GP fittings, or do you have a preference between that and the Pinacam at all?
The answer to the question is I prefer the Pinacam. So the Pinacam for GP and ortho-K lenses, for me, hands down, it's just more real, reliable, trusted kind of corneal data. Having said that, you can use the eaglet for corneal and ortho-K lenses, and I have done it on both, mostly just to help them, with algorithms and development and kind of beta testing some things. So it definitely can be done. And I have had a couple cases of corneal lenses that we just weren't able to get, as high quality maps from the Pinacam as I had hoped. And because but if we can get a decent tear film and, with the eaglet, then that data works pretty well. So for corneal lenses, yeah, that I feel like that's pretty reliable. But for ortho-K, it's so precise that we're talking like really a handful of microns sometimes. I would probably really just lean toward the Pinacam if I have the option.
Okay. And I think this will be our last question, if that is all right. This is just regarding materials. Do you have a standard material that you usually design for, like in keratoconus cases at all?
I don't have a standard material. I try to think about like whatever that particular case, is. A lot of the material will somewhat be determined by the size of your lens.
Mhm.
And then if you do or don't want different colors, Catherine, we've talked about this, in the past, where it's like, okay, I can get a certain material in that size, but I can't get it blue, right? I have to get it clear on both eyes or something. Or if I do a different material, I might be able to do clear on the right and blue on the left, which is something I commonly do. But but then it's just whatever's available in that particular size and that particular material or color. So it's not a one size fits all, as far as materials go. But I will generally maybe start with something like an XO2 or an Extreme, Optimum Extreme. Those are kind of good, safe places to start from. If I'm, again, particularly worried about like a at-risk cornea or something, you can get a QD200. You can Optimum Infinite with wave lenses. So I'll use those, and then for my dry eye cases, I'll almost exclusively go with Optimum Extra.
Okay, yeah, that is great. And that was our last question. If any more come through right at the end, we can always try to follow up via email. And thank you so much to everyone who attended our webinar this evening and submitted the questions. And thank you again, Dr. Wolf, for presenting cases. Those were really interesting. Those were great.
Yeah, thanks for having me.
Yep. And with that, that will conclude our presentation for this evening, everyone. And on behalf of WAVE, have a good night.